Good evening to everyone. See, make sure we got everyone in. All righty, come on, camera. We have about 45 seconds before we officially start. Good evening to everyone. If you would go ahead and place your name and campus in the chat. Give you a minute or so to get that done. Once you place your name and campus in the chat, please be sure to check your screen name. You want to make sure that it matches your name, how it appears actually on the roster. If you are undergoing a name change and it has not officially occurred, make sure your name on the screen actually matches what it is on the roster. You don't want any confusion of thinking that you're not here when you actually are. All right, so we're going to call it official start time. So good evening to everyone. Welcome to Mental Health. We will be together for 3 weeks. It is a short time, but we are here a good amount of time to cover everything. So no worries about not having the content and not going over the content. So I am Dr. Ford. Been with Ford's for a couple of years now, several years. And so teaching a variety of courses. So you may have seen me in others, or you might go in the future, you might see me in others in both programs, the PN program and the RN program. So happy to be here. And so let me just go ahead and share my screen here. So good evening for those that are just coming in. Place your name and campus in the chat. You all have went through the orientation PowerPoint in a class for week one, your official week one. Is that correct? Okay, so you know about logging in, who you contact in the event of there's questions or concerns. But I'm going to show you the about instructor tab because for some reason, that's our little timer. We sometimes can't find it. So no matter what your courses are, and this should be section B. This is section B. Everyone here has B on their schedule. Okay. Let me pull it up here. So you do want to, hopefully we did share that orientation PowerPoint with you all in week one. And so know that it's there in the announcement section because sometimes you have to go back and just refer to it, especially in the event that have you missed classes, running late for classes. Remember, I like to always, refocus and bring that to everyone's remembrance about the time. Everything matters. And so over time, that 1 minute late, that 5 minute late, it adds up to 15-minute increments. So just make sure, usually the Zoom is open at least 5 minutes. A lot of times it's open even earlier than that. So just go ahead and log in and then you can go ahead and complete whatever task that you are having to do because those minutes, they do add up. So I just want to show you this right here. Modules, and this is for all of your courses. In the event that you need to quickly talk to your instructor, professor, you can go to the About tab, and you all may know this, have seen this before, but I just like to show it to everyone right here. So you have these tabs, and this is quickly how you can, our Zoom is there, our emails, and all of this is quickly here. Because sometimes, you'll have your information somewhere and you can't put your hands on it. So just know that that tab is there. Okay, so we've already done orientation. Are there any questions before we get started? So we meet this week and next week. And then that third week, we meet at the beginning and we kind of do like a review. And then we take the exam at that latter part. So yeah, so the expectation is that you're on camera, unless we're on break. But in the event that you have to step away, get your notebook, use the restroom, you know, stand up for a moment or whatever, put a message in the chat to me. Don't send it out to everyone. Therefore, the attendance administrators, because they review these videos, and if they're questioning, why wasn't Dr. Ford on camera, there's a message in the chat that says what I was actually doing. So that's fine if you have to step away. So yes, we are here until I was gonna pull that time up. what we usually do is we do like a 5 minute break, 10 minute break, and we push most of our time toward the end. So we're not getting out early because that's your break time, and that end time is shorter than it's less than what is listed. But you don't get out early. It's your time. Is that you are understanding what I'm saying? I'm pulling up the class now to see what time. So we are here till 9:06. But if we chop up our break time, we more than likely we're going to finish before then because we'll push some of our break time toward the end, even if it's nothing but 10 minutes, you know. So that's why I say if in the event that you need to step away, use the restroom or tend to something real quick in your surroundings, just do that, put a message in chat, do that, and come on back because we are covering, a good bit of content in 2, 3 weeks. All right, so without further ado, let's get started here. So we have 6 chapters that we'll go over tonight. So don't let that number overwhelm you. Let's just absorb what is the content that's there, that's in front of you. And I want to tell you too, now my PowerPoints are the same PowerPoints you have. I think I have a theme for color and design and pictures. So I take those PowerPoints that's in your announcement section. I download them and I add pictures and colors and I may add some animations to it. So don't get thinking that they're different PowerPoints. And some of the PowerPoints, the slides have a whole lot of information on it. And what I'll do is I'll piece it up, put 2 sentences on it because I need you to absorb and gain the understanding and just think about one concept at a time. So the PowerPoints are the same, but yes, I've added my colors and all my little specialties to it. So let me share here. So, all right, and we will start our slideshow from the beginning. And how we do participation here is, sometimes I'll ask you to come off mute and share verbally, and then sometimes I'll ask you to type in the chat, and then we just kind of mix it up. Okay, so we're chapter 18 is about managing anxiety. You do have the objectives there. Now, the objectives are a good way to go back and create your to-do list of the topics or concepts that you need to start with first. So, for example, if you looked at objective number 2 and it says identify 3 types of coping mechanisms used to decrease anxiety. And after you sit with that question, that objective for a moment, if you're having trouble identifying 3 types of coping mechanisms, that needs to be at the top of your list of where you need to start reviewing. So then you will look at the next objective. If you can come up with an answer pretty quickly or have an answer for it, then that will be at the bottom of your list because that means you do understand that material. So object that's a way of studying and kind of testing yourself to see if you're ready for the exam so that you can use that technique. And I'll throw little test taking tips in throughout our sessions here. So let me just make sure. Want to be good stewards of our time here. I have to refer to my little clock here. Okay, so I'm gonna take this off the screen here. So I just want to hear your voices. Anxiety. I need to hear at least 3 different people. We're gonna take our turns. Just tell me what in your mind you are reinforcing teaching, and your client is in the urgent care, and you're reinforcing teaching, and they're asking you, well, they say I have anxiety. The nurse told me already, but can you just go over it again? What's your explanation? What would that sound like? So I need 3 people, come off mute and tell me what would you tell that patient in that reinforcement? And they're asking about, what's this anxiety that they telling me that I have? Okay.
I'm having a feeling of being tense or edgy.
Okay. Thank you. Next person.
Sometimes, sometimes anxiety it can be in different situations. Like it can come from trauma. It can give you very bad anxiety or um how you feeling or being overwhelmed in certain situations.
Okay.
And that can give you anxiety too, that anxious feeling. Very anxious. Sometimes it can make you scared, shortness of breath. It can do many different things to you.
Okay. Next person, we're talking with the urgent care, and that patient says, "Hey, the nurse came in, the RN came in, and she told me all about this anxiety that the doctor told me that I had, but that they're going to ask you one more time. Hey, what is this? What are they talking about? What is this anxiety? What would you say to them?
I would say like just excessive worrying, like worrying about every little thing.
Okay. Yes. And so, I think you all are in going to your clinicals, your various settings, and your patients are asking you questions. So yes, this is where we test it out at. We test those things that we say because they're going to be these things that we're discussing. These are things that our patients might have. And so yes, they're going to want to know because we're establishing those therapeutic relationships up front. And so they're going to feel at ease with you asking these questions. Okay. So, yes, you all were spot on. A feeling of uneasiness, uncertainty, and helplessness. Like, I can't do anything for myself. A normal emotion, response to real or imagined threat or stress. So, this imagined threat, and then some people say it's not really an imagined threat, but people, for example, a spider. I see a spider, like, I know it's not going to chew me up, but I don't want it next to me or near me. So it's like, get rid of the spider. So that's kind of an imagined threat. So serves several purposes now. So a warning of impeding danger. Have you ever experienced going, I don't know, maybe walking down the sidewalk or walking in your neighborhood or taking out the trash late at night? Look, this being taking out the trash because we know the trash is going to run early the next morning and we don't want them not to pick up our trash. So it's like midnight or 1 o'clock, 1 a.m. I'm out there lugging this bag of trash, like, oh my goodness, is someone out here, peeping or whatever. So, but it warns you about impeding danger. Have anyone ever experienced where you were going to do something or going to go somewhere and something kind of said, hey, some uneasiness, said, no, don't go right now? Anyone experience that? Okay. And so mild anxiety can increase learning by enhancing concentration and focus. And because I'm taking that trash out at 1 a.m. in the morning and I have that little uneasiness, okay, I am watching, making, aware of my surroundings. And see, but uncontrolled anxiety often leads to ineffective and maladaptive behaviors. So test taking tip. Make sure that you are responding to the type of anxiety that it's asking about. Is it mild anxiety, or is it just, anxiety, or is it uncontrolled anxiety? Then those are different things. Okay. And anxiety is a normal part of survival and growth. So reactions to anxiety occur along a continuum of behavioral responses. Positively focused anxiety helps us to adapt, to learn, and grow from our experiences. Now, had I'm taking that trash out at 1 a.m. and I'm looking, being aware of my surroundings, and I kind of heard something rumble in the bushes, then the next time I probably would have taken that trash out a little bit earlier. So we learn and grow from our experiences. We are, I can remember we were at some conference and, I guess I don't know. I guess we were just being greedy. It was like, okay, it was late at night. Let's go to whatever restaurant that's open in the little area. So we're out walking and whatever. It's like, wait a minute. And then so these people approached us, but really, we really shouldn't have been out that time of night walking, trying to, just get some exercise and go get a small bite to eat. And so from that experience, we learned, hey, for your safety, don't do this again. Get your snacks prior to, going in, turned in for the night. So I need you to pay attention to what this maladaptive responses to anxiety are ineffective. So make sure when you're reading your scenarios, pay attention to the words because effective is different from ineffective. Maladaptive responses are not coping responses, they're not good responses. So, responses to anxiety occur at 4 levels, ranging from mild to panic. And I'll stop every now and then. If you have a question, You can put it in the chat and or you can come off mute. But I do want to take time to make sure that we're reading through this information because we really do, you all, cover your content in through these PowerPoints and everything. But sometimes, like I say, those PowerPoints are just so crowded, you kind of skim through them. And after students go back and look at after they take the exam, they go, I said, well, go back and look at the classroom recording, look at our PowerPoints, and let me know if you see any information that is there that is the answer to the question that you missed is there. So I just want to take our time to go through it. And I may need to change the background of my slides too. I was trying to be fancy. But anywho, nevertheless, we're gonna move on. So anxiety occurs as a result of a perceived threat to oneself. So types of anxiety, we have signal anxiety. You need to know all of these. It's a learned response to an anticipated event. Okay, so like I ran track back in the day, right? And so it's like, okay, they're getting ready, it's getting ready time for me to take off. So it's like, that anticipated event. An anxiety state, individuals' coping abilities become overwhelmed and emotional control is lost. So our child is sick, not feeling good, have a fever, stomach is aching, haven't experienced this before. It's new for her. So, so she's crying and just overwhelmed because she doesn't really understand what's going on with her. And then some of our patients they may experience the same thing. They get excited or anxious because they just don't know, you know, well, why is my head hurting? Why is they have a broken bone. Why is his arm hurting so bad? Well, ma'am or sir, that bone, is broken. And so, that's not the normal state. So you're going to experience some pain. Patient just had surgery. They had a hip replaced. Once those nerve endings and that tissues, they start waking back up, so to speak, those nerve endings that hurt. And so they will experience that pain. And so sometimes our patients will become overwhelmed by that pain because they were not expecting that type of feeling. So anxiety trait, learned component of the personality. So when conducting a history, you need to know this to assess stress. So remember, we're going in, we're using ACT, right? Remember, bring all your tools from Med-Surg, bring all your tools from all of your other classes, because the nursing process hasn't changed. We go in and we do an assessment. We're gathering information. So while we're talking with our patients, we're assessing level of orientation. We're asking them about their history. When conducting a history to assess stress, the nurse should query, just I don't think that means is ask about past and current state of health. What has your health been like in the past? Would you say that you were healthy or you didn't experience anxiety? Just you can give them some examples if they're kind of not understanding what you're asking them. But you want to know about their past and their current state of health. If you want to, would you compare your current state of health with your past? Would you say now is worse or better? That's just some examples. We want them to include and tell us about their past medical history and also their medications that they've been taking and also their past medications. Because we know with the past medications, it will allow us to learn what they were on and why they probably more than likely are not on those medications because it might not have worked. They may have experienced some bad side effects or whatever. So, but when conducting a history to assess stress, we need to know about their past, current state of health, the medical history, and their current medications. A thorough medication history helps identify potential drug interactions or side effects. And we may say pharmacy is there, but that will lessen the time if a healthcare provider already knows or this patient has already taken this medicine and this is what they experience. They experience, more anxiety, or it made their feet swell, or they had an allergic reaction, or whatever that is. That lessens the chance of that doctor ordering that medication this patient has already been tried on. Now, that doesn't mean that doctors won't go back to some medications to try them again. But nevertheless, we need that thorough medication history to identify potential interactions or side effects. that may be contributing or mimicking psychiatric symptoms. That app, how we're assessing, we're gathering all that information. And so we're talking in the vein of mental health. So we need to know medications, what their current and past health history is. All right. So in the chat, I'm going to use the chat this time. List one. It says, what are some other physical coping mechanisms for anxiety? So just think about what when you were anxious or what some patients have told you that they've done to cope with their anxiety. In the chat, it just sent it out to everyone. So just give you a minute to respond. What are some other physical coping mechanisms for anxiety? And you just select one and just share it out. I like to give you enough time. Sometimes this clock, the time been ran out by the time I get the clock up. Okay. Give you time. Coping mechanisms. Let's see here. Let me see what you put in the chat. Okay, yes, aromatherapy, deep breathing, exercising, walking, coloring. That's a big thing now. That is a huge thing, that coloring. Walking, yes, meditation. Good, 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 great. Okay, coping mechanisms and what you've listed there falls under one of these three sections here: intellectual, spiritual, or emotional. Great. Okay, so simple, concrete questions are easier for patients with disorganized thought processes to understand and answer. So think about what you just said. I asked you all about if you were telling someone about anxiety, what would you explain to them? You all said, a person may feel some uneasiness, their breathing may change. And so if our patient is experiencing anxiety and we're trying to gather that health history from them, you're trying to get their medication history, we're trying to just do our head to toe assessment. We need to make sure that we're talking in simple terms. Remember, more than likely our patients are not healthcare providers. So we want to make sure that we're speaking in terms that they understand. Because remember, we had to study to learn these terms that we know. So if they're not a healthcare provider, the terms, if we're using, even just hypertension, sometimes pretty much people know what hypertension is. But saying that high blood pressure is a simple term than hypertension. Making sure that our questions are concrete. And because think about it, if I'm anxious, and you're trying to get me to focus and you come with all this elaborate long speech, I'm going to get even more anxious. And am I going to, as a nurse, excuse me, am I going to be able to get any information from the patient? No, because they're already having this organized thought process. They're anxious and they're not able to refocus. So no, we're not going to get anywhere. So simple, concrete questions. Okay, this approach helps maintain focus and clarity during the assessment. Okay, good. Uh-oh. Why is that so small? All right, so our next thing is subjective and objective data. So tell me, someone come off mute, need one person to tell me what is subjective data and the other person to tell me what is objective data.
Is subjective data what the patient tells you?
Okay.
And it's not something you can measure, but oh, sorry, you want somebody else to answer.
Oh, okay, so go tell me that again.
Subjective is, oh, my bad.
I think your mic turned to you went on mute.
There we go. Subjective is something that the patient tells you. And then objective is something you can measure, like vitals.
Okay. So one other person, tell us about subjective and objective.
Objective is what you observe as the nurse, and subjective is basically what the patient tells you.
Okay. So when we are documenting, we want to include both subjective and objective data. We want to include those nonverbal cues as well. And remember, objective data, we are using pretty much 4 of our 5 senses. Of course, we're not tasting anything, okay? But what are we, when we touch that skin, what are we feeling? When we hear that blood pressure, when we look at that patient's describing their affect, what are we seeing? A smile? Are we seeing, is the affect flat? So what are we observing? Okay. So subjective data, I was trying to make that larger. Subjective data in a mental health assessments relate to the patient's perceptions. So it's what the patient tells you, right? So it is what they're feeling and they're experiencing. And we may not exactly observe what they're saying. We can't even measure it. So if they're saying that their fingertips are burning, it's what they are perceiving. We write down because that's what the patient, the resident, the participant, depending on what setting you're in, is what they call them. But nevertheless, is what that person is telling you, is what their perception of it is. You can ask them, is the temperature of the room okay? Because you walk in and the room is steamy or it's freezing cold. And they say, oh, it's perfect. We're writing down, patient states the room temperature is perfect. We write down whatever it is that they're saying. The patient's report of feeling anxious and restless is subjective. If they're saying, hey, I'm anxious, I'm restless, is whatever they say. Information is based on the patient's internal experience. Objective data, you're right, as they can be directly observed. We are seeing the patient with slump posture. We observe the patient not making any eye contact. We observe the patient, guarding their stomach or whatever it is that we observe. That blood pressure measurement, we hear boom, boom, and we see the measurement, the numbers on the dial. So objective is what we observe, measure by the healthcare provider, whether or not it's the nurse or the physical therapist or whomever. Okay. So here's some examples. Okay. So I need you. So I don't have numbers here, but I can put numbers. Oh no, I can't. Okay. So number one in the chat, I need you to put S or O in the chat. Just put S or O. This is your first response. S or O. Okay, everybody got their first response in. Okay, your second response, just put an S or O. So read the statement and remember the question is asking you to decide, is it subjective or objective data? Now, you all just told me what subjective and objective data was. Remember, next gen, these questions, you will have to know what the concept is and be able to apply it to the situation in order to, gain your points. So patient reports feeling being nervous and anxious or restless. Put mine down. Okay. Number three, your third response. Patient's affect is congruent with the mood, pleasant, smiling. Is this subjective or objective data? Okay. The patient's score on the mini mental state examination. So I don't know if you all were able to actually administer these or see this instrument that they use, and they have all these questions. They call them mini mental. So, but the patient score that's on there. Okay, put an S or O. All right. So now I need someone to tell me, what did you put for number one? Is that subjective or objective?
Objective.
Okay, so I do agree. So check what everybody else check and see what you put, what your first response was, and see did you mark it correct. Okay, someone tell me, what did you do for number two? Patient reports feeling being nervous and anxious and restless.
S.
So subjective, because the person is telling you this, they're reporting it, they're stating it. So don't get tripped up on words. Report, states, telling, that all means the same thing. Okay. So number 3, patient's affect is congruent with mood, pleasant, and they are smiling. S or O?
Objective.
Okay. Because what we are observing, right? We're they're not angry. They're not, the voice isn't raised. They're sitting and we're just having a conversation. So these are some descriptive terms that we can use because this is what we are observing. Okay. Objective. Okay. So what about that patient? The last one, the patient score. They scored or whatever the number was they scored. What is that?
Objective.
Yeah, oh.
Is objective as well. Got it. Good, good, good. Because you all just told me subject. So test taking tip. Read the question, identify what the concept is that the question is about. This was about subjective and objective data. So then you go back through your file, you have the knowledge, but what is subjective? That's what the person, the patient, that's what they're telling us, whatever they perceive. Okay, objective are these things that I observe. Okay, now read each answer choice. We just did. Good, good, good. All right. So physical symptoms of anxiety. Some of when I was asking you all to reinforce that education with the patient that was asking you about anxiety, you all mentioned, you all reinforced, hey, you might feel some of these symptoms: muscle tension, fidgeting, headache, problems with sleep, fight or flight reaction. So coping mechanisms in the physical realm include efforts to directly face and handle the problem. Intellectual coping mechanisms are aimed at making the threat less meaningful by changing one's perception. So intellectual, I change how I see it. Like, okay, the example, I'm walking outside at 1 a.m. to put the trash out, you know, rather to keep myself from getting all worked up, know that I'm safe. Nothing's going to happen to me. I changed the way I'm thinking about being out at 1 a.m. in the dark, taking trash to a road. Okay, so I changed the way I think about this. Intellectual coping. So, and then any questions so far? No questions. All right. Defense mechanisms, psychological strategies that help to lessen feelings of anxiety. The goal is to decrease uncomfortable negative emotions, you know, and we'll talk about this a little bit more on. People may have to remove yourself from the situation. A lot of times the students have reported, like when we've met and talked about how did they prepare for the exam, a lot of times they said, well, we were in a group setting. And well, how did you feel in that group setting? Well, I got anxious. So therefore, if you're anxious, you're not really focused on what the group is talking about in regards to learning and understanding the concepts. So you might want to put that as move that down on your list of how to review and get ready for your exams. Because if you're in a group setting and you're getting anxious or distracted, you're more than likely not going to absorb the information about the concepts for whatever you're studying about. And so, and students were like, "What? Yes, because if you're anxious about it, you're blocking the reception of that information." Okay, and so the goal is to reduce uncomfortable negative emotions. And then we have crisis. One's ability to cope with anxiety is overwhelmed. New coping behaviors must be developed to successfully resolve the source problem. So then the patient might ask, well, what can I do to help to not get anxious? Okay. All right. So self-awareness and anxiety. Be aware of, you're feeling yourself getting anxious, walking out at 1 a.m. in the dark with the trash. Okay, just calm down. It's gonna be okay. You're gonna walk up here and you're gonna come up back in the house. You have to refocus. It is safe. Anxiety is contagious. In the event that there's a group, and remember the example I gave you, we wanted to snack, and we're gonna walk down the sidewalk. Now, a few of us got anxious, but a few remained calm. And so if everybody would have gotten contagious and everybody would have gotten anxious, then we might not have walked away safe, unharmed. So anxiety is contagious. So be aware of especially if you, I don't know if you all have been in a facility and you all may even work in a facility where you do the fire drills or actually had a real fire or we know storms are going through and those alarms go off. You have to, because you're going to be leading the safetyness for you and the patients and the other staff, you're going to have to maintain calm, refocus yourself so that you can give those clear, distinct instructions as what to do. Remind people we need to get the fire extinguisher. Okay, remind we need to pull our patients out in the hallway. We need to, and so we just be aware of if you're getting anxious. It is important for caregivers to recognize and cope effectively with their own anxieties. Caregivers and those that are leaders, like the example I just gave about you being the charge nurse, at that long-term care facility. Okay, we may not choose our anxieties, but we do choose how we deal with them. Taking out the trash, refocus my mind. I'm going to be safe. Place the trash. I'm going to come on back. Okay, so we have a bunch of theories that are related to anxiety. And as you continue your journey and as you go into your other courses, you're going to be exposed to all these different theories. And these theories are like our guiding point for whatever intervention that we want to implement. And there are all types of theories out there. So anxiety in childhood, it could be related to that child's developmental level. For the example that I gave, the 1-year-old, they're experiencing stomachache, fever. And so there's something they haven't experienced before. And so their response, and they really can't talk to you at 1. So their response is just to cry. So depending on that child's developmental level is how their responses would be. Okay. Anxiety in adolescents, adolescents who ineffectively, remember, look at our words correctly, who ineffectively cope with anxiety often express themselves inappropriately. So they're in this group setting and, they're getting anxious and they're not able to refocus that mindset or that thought process, then what they may say or even their reactions, more than likely they're going to be inappropriate. They may, use some verbiage or say things that's not even related to what's going on. They may even strike out, but that's inappropriate. Many initial symptoms of schizophrenia and other psychosis begin in adolescence. And then, and so we tend to have, sometimes it's missed, the child's behavior is just chalked up to that, oh, that's just how they behave. That's just what they do. But in fact, it might be a symptom of some mental disorder. Okay. So healthcare providers who work with adolescents must assess adolescents' anxiety levels and offer early intervention, giving them the tools, the coping mechanism, the refocusing, the strategies to refocus themselves so that they don't express themselves inappropriately. Okay. Anxiety in the adulthood, similar to their younger counterparts, adults handle anxiety by using established coping mechanisms. By adulthood, we understand a little bit more. Just like I said, I'm just taking out the trash. Why am I getting worked up? So I kind of, refocus myself there. When adult anxieties are not successfully managed, a number of mental health problems may result. Okay. So elders often deny that they have anxiety. Socially, many were taught that it's inappropriate to share their feelings and anxieties. So, now we know it's better to express and share those anxieties so that we can come up with a solution, so to speak, coping mechanisms. Okay, one of the most effective methods for assessing anxiety in older adults is to simply ask the client to explain his or her anxious feelings. Well, tell me, what are you feeling? Going back to the group, the student that was studying with the group, she said she really didn't hear any of the information. It was like people were just talking all together and things were just running together. So she never really clearly heard any information about the concepts. Therefore, she wasn't gaining any understanding. So asking them to explain. Okay. So diagnosis of anxiety disorder is based on a description of the behaviors that express distress. Okay, so we will, um, so what do you think separation anxiety is? Some terms are exactly what they say.
My dogs are separation anxiety.
Okay, so what is that? Give me a little bit more detail.
They follow me around the house, and when I'm about to leave, they get like really sad and they don't want to do anything else but like look pouty and they're like, "Oh, what are we gonna do without you?"
Exactly. And we do see that in our pets, and also for the young child that's going to daycare, or or that first or second grade. So yes, they don't want to be separated. So generalized anxiety disorder, we'll have this one. Individuals' anxiety is broad, long lasting, and excessive. So this is where it's more than just getting a little anxious and refocusing yourself. It's worried and anxious more often than not. Okay. All right. So panic disorder, need to know. First, rule out medical causes for acute symptoms. When someone comes in and they may be experiencing, disorientation, maybe some mental health signs and symptoms, we always have to rule out medical causes. So more than likely, they're going to draw labs, check that CBC, that white count, all the basic labs. They will get a urine sample just to make sure that, there's not a urinary tract infection, because I don't know if you all have seen some people that have urinary tract infection, especially older adults and young, our children, if they have a UTI, their mental status just kind of change. And so we want to first rule out medical causes for what the signs and symptoms that the patient is experiencing, just to make sure it's nothing medical. Then we want to reduce the environmental stimuli. So if the client is experiencing, you know, overwhelmed by the noises that they hear, we might want to, move that patient to, a different room where there's, especially if they're on like that main hallway. If they're living in like a long-term care facility and their room is located on that main hallway that's going to get all the traffic that comes in the door, and they get antsy or anxious, on, we'll say, Saturdays at noon, because that's high traffic days, and they realize that this is when it's happening. That patient might need to be removed from that room and put in a different part of the building where there's not as much environmental stimuli. In the hospitals, we hear sounds all the time. Monitors are going off. We want to make sure that we are answering and resolving those beeps and all of that. If our IV pump is going off, people are ringing their call lights. We need to be resolving all of that. That is the environment. Therapeutic presence and reassurance help the patients feel safe. Now, no, we're not going to give them false hope, but we do bring them back to reality and state things that are true, and that will help that patient refocus and feel like they're safe. So deep breathing helps regulate autonomic arousal as well. Someone, I think, who put that in the chat when we were talking about coping mechanisms. I think I saw it in there. Yes, deep breathing exercises. Sam said it. Several of you all, Diamond, Eves, yes, you are spot on. Great, great, great. So these are things that we can use, and also we want to reinforce with our patients. Deep breathing exercises. And I often do this a lot too when we're checking blood pressures, especially if they come and say, oh, it's going to be up. So we had a patient just sit for a moment and, just tell them to take that deep breath in and then just blow it out nice and slow. Do that like 3 times and then breathe normally. If that patient has refocused themselves, not to say the blood pressure is going to be low or either high, either way, but we're checking that blood pressure with that patient at that calm state, that deep breathing. And the patients, they be like, oh, I just feel better from just taking those 2 or 3 deep breaths and just, controlling that air go out. So yes, that's good. All right, so I had it again. Deep breathing is a technique used to manage emotional responses to stress, because we know our patients sometimes get stressed out, have to come to the doctor. They see us with those uniforms on, they see those name tags, they see those stethoscopes. They just get a little anxious and stressed. So deep breathing is that technique that can be used to manage emotional response to stress. Make it an example of emotion focused coping. So emotion focused coping, need to know. Okay. All right. So we do have phobic disorders. So a phobia is an internal fear reaction. Phobias differ from common fears. Phobia is obsessive in nature. So give me an example. Someone can come up to you and tell me, give me a couple of examples of a phobia that someone might have.
Scared of spiders.
Okay. And then with that being afraid of the spider, like I mentioned earlier, I see the spider, I go ahead and whisk them on away. But if I really have a phobia for it, would I just whisk them on away, or might I do something else? If I have a phobia.
I do a whole lot.
What you say, Miss Smith?
I said you might do like more than just, you're probably not going to whisk it away, go try to get away from it.
Exactly. I have a relative that's afraid of cats in this life. She gets so worked up. She will actually harm herself trying to get away from it. Like I said, the spider, I may just whisk it up and, throw it in the trash or throw it back outside. But if someone actually has that phobia for it, they may end up almost hurting themselves or you trying to get away from it. Okay. People with phobias handle their anxieties ineffectively. Like I say, instead of just whisking a spider away or just moving myself away from the cat, she's running, almost falling, breaking bones and things because she's trying to get away from the cat. That is handling it ineffectively. Okay. So obsessive compulsive disorders. Tell me some examples of that. If someone has that, what are some things that you've heard or your patients have shared that they do? Some
The
rituals
way
they
things
might
have to be clean, like it has to be a certain way. They have to like be organized in a certain way. They pretty much notice if somebody touched something or put it like out of its place or something.
have. Okay. Someone else give us another example.
Is it fear of germs?
And so what might that person do? What might that person be doing repetitively if they are
Washing their hands, because that's where the most germs may be until, they're really um sensitive. Like your skin gets so sensitive from washing them so much.
exactly? Someone in the last group gave an example where their loved one would go back and check the stove. Was it 6 times, 5 times, or 7 times? They had a specific number where they would actually go back and make sure the stove was off. So remember, with these, they are handling their anxieties ineffectively because once or twice, okay, check the stove is off, but 5, 6, 7, 8, 9 times, that's inappropriate. And so that's a negative way of or ineffective way of handling it. Okay. So there are all types of disorders out there, hoarding, they have a TV show about that. They're all different kinds. And they specifically have names for them. Even people can be having addictive behavior where they're to gambling. Well, they know that they don't have the funds, but they continue to get funds from somewhere and just gamble. Okay. So stressors and trauma disorders, traumatic stress reaction, series of behavior and emotional responses that follow an overwhelmingly stressful event. Something happens, and it's whatever that patient perceives as overwhelmingly stressful. We might not deem it stressful, but if they do, okay. Post-traumatic stress. It is they're reliving some event or a situation. It is if they viewed it as being traumatic, then it was traumatic, but they're reliving it. Progressive muscle relaxation is particularly effective in managing physical symptoms of anxiety, such as muscle tension. So I think what someone said, meditation, yoga. Did someone say that? Okay. Walking. So that would be an example of releasing that muscle tension. Okay. That muscle relaxation. Going for that nice stroll, doing the yoga. The new thing that I've been hearing about is Tai Chi. I don't know what they really do, but it's some type of muscle relaxation and focus. But that's an effective way, a positive way of handling that anxiety or stress. Okay, so pathologic anxiety usually occurs after the individual experiences or witnesses severe trauma that is terrifying or life-threatening. Symptoms include intense um, fear, horror, or helplessness. Individuals can become emotionally numb, extremely alert and guarded, and easily startled. Okay, so rape trauma syndrome, reactions to trauma, especially rape trauma syndrome, following a predictable clinical course, fear and anguish, recovery and repair, and then they learn to adapt. But this fear, anguish, they may be angry at themselves, I decided to take the trash out at 1 a.m. Why was I taking the trash out at 1 a.m.? This wouldn't have happened if and so, and then, therefore the patient might be afraid to leave the house going forward. But providing that psychological stability, emotional support, patient might even need medications. But remember, interventions can be non-pharmacologic, things like emotional support. These are not medications. A support group, a help group, and advocacy are the most important therapeutic interventions. Sometimes it's medication or pharmacologic, but sometimes these interventions that are really good are non-pharmacologic. Just having that support, knowing that someone's there. It's not all the time that they want the person to have the answer, but just knowing that person is there. Okay. So prevention, most effective ways to cope with anxiety. Someone already said meditation. I want to read through this right here to make sure, because I know we have cognitive behavioral therapy. You need to know that. So let me read through this. Mental health therapies and medications frequently are used to treat, or used as treatment, medications and therapies. History and physical examinations are performed. We just said we need to know their past, current status, past and current, past health history, the medications that they've been on, and their current medicine. So that's all part of this history and physical examination. Cognitive behavioral therapy helps clients intellectually understand ineffective behaviors used to cope with anxiety and replace them with more successful behaviors. Okay, so we're replacing with something that is more successful and it's not going to cause them any further harm. Systemic desensitization. Clients learn to cope with one anxiety-provoking stimulus at a time. And so with this right here, I think I saw it on, I can't remember what that show was, some show. I'm learning to watch TV now, so I'm looking at all these different shows, so I don't really remember what they are. But they were using some type of desensitization technique where were exposing a person to whatever it was. So like the example about with the spiders or the cats, they may show me a picture of a spider, a picture of a cat. And then eventually they may have a stuffed animal, that's a replica of a spider or a cat. And then, after so much time, they will have a real spider in the room. And so taking those steps from the picture to the stuffed animal and so forth is supposed to desensitize or make you numb to having that fear or being anxious about the cat or whatever it is. So anxiety may be treated. Of course, we have several different medications. Now, we do want to note that, I think I may have it on a different slide about the different medications. So I don't see that, but just know that they're different meds: antidepressants, antihistamines, analytics, benzodiazepines. There are a lot of different medications that patients will be taking. So anxiety may be treated with, you already said this, regular exercise. It is an effective non-pharmacological intervention. Not everything's about medicine. For managing their anxiety, it helps reduce the stress. It improves the person's mood and promotes better sleep. Okay. All right. Need to know. All right. So recognizing and preventing anxiety. We talked about completing that health history, gathering all that information. We want to establish those therapy relationships with our patients. That does not mean that we are breaking rules and changing policies and procedures, but we have shown that we genuinely care for our clients, our patients, no matter their pay status, no matter their ethnicity. We're there for them. We're providing those individualized interventions and care plans for them. Okay, so let's look at this again. This is a recap. We said separation anxiety disorder is excessive worrying about being away. Gave us an example about the dogs. The child that's going into kindergarten or daycare, they are excessively worried about being away from whatever that is, the owner, the mom, the dad. Okay. We have obsessive compulsive disorder or OCD. It involves intrusive thoughts. These are obsessive thoughts. It's like on. Continues to repetitive thoughts. Repetitive behaviors to reduce anxiety. Then we have PTSD, which is post-traumatic stress syndrome. You need to know all of these. Follows exposure to a traumatic event. Now, if you look at the words, some concepts, the words could help you remember what they are. Separation, obsessive compulsive, post-traumatic, it's happened in the past. And then we have generalized anxiety disorder, chronic excessive worrying over multiple domains, often with physical symptoms like fatigue, irritability. So the separation in the generalized disorder, they're both excessive worry, but this one is about separation from a person or a thing. And generalized anxiety is not specific to being separated from a person or a thing. So, okay, so we need to know those. Almost at the top of our first hour. Okay, here it is, cognitive behavioral therapy, particularly exposure and response prevention, is the first line of treatment for OCD, often used in combination with medicine. So even though we have those non-pharmacologic interventions, sometimes they may need those, the support systems, the help groups, but they also may need a medication. Okay. So positive, and I don't know why I put that down there. I think it moves when you add those different designs to stuff, it moves it. So positive coping strategies help manage stress constructively. It improves emotional regulation and promotes overall well-being. So if someone is displaying or using or know about positive coping strategies, they're less likely to respond inappropriately. Okay, so we have examples include art therapy, counseling, distraction, diversion, education, massage, meditation. You all put some of this in the chat. Praying, social support systems. Yeah. Let's bring it back to the regular size. Okay, so we have coping mechanisms, but now we have maladaptive coping behaviors. So they temporarily reduce the stress, but often create new problems and worsens what's going on. So maladaptive coping behaviors are not good behaviors. They're not good coping strategies. So some examples include avoidance, attacking or bullying, denial or dependency, emotional outbursts. So these are things that are not good for responding or handling or coping with whatever is going on. Okay. Coping is defined as an action directed toward change through conscious or unconscious thoughts and behaviors to avoid harm and to restore that balance. Okay. Coping. So we're trying to get back in that balance. We're trying to respond appropriately, and that equals coping. All right, so I'm gonna stop sharing, make sure I don't have any questions in the chat here, not seeing any. Let's just stop and take a 5-minute break. So what time is it? So return at So I'm on a different time zone use. Make sure I'm writing this down correctly. Return at 6:37. That's Eastern time. So this video still runs, you all. So make sure you turn your cameras off and make sure you're on mute. So return at 6:37 Eastern Standard Time. We have about 45 seconds before we retire. All righty, come on back. Let's go ahead and travel a little bit further. All right, so are we understanding? And I make up some situations and scenarios just because I know next gen you're gonna have to be able to apply what you know about the concept. So if I need to give some more explanations and some what if scenarios, I can. So again, just be careful with ineffective, effective, coping, maladaptive, those terms, they mean different things. Okay, so we actually made it to the end of that one. All right, so that's chapter 18. We did pretty good. So let's change up here. I'm gonna pull up the Kahoot. Give me a minute to just log in here. Hold on. You can go on over to Kahoot. I'm just getting it. I'm getting logged in. So give me just another minute or so. All righty, it is loading. Let me share my screen so you can join. So let's start. And then it's going to give us our game pin. Okay. So just go to www.kahoot.it and just enter this game pin. And you can just place at a minimum, you can place your name, you can put your initials, that's fine. Give that little music. Now, Kahoot is based on your speed of answering the question, but I want you to make sure that you read through and make sure that you're answering correctly. Because I want, as we do this exercise, you need to still identify those things that you need to put at the top of your list. The things that are at the top of the list are those concepts that you are not as don't that you don't have as a strong of a foundation on, that you know less about. So this is going to help you figure out what's going to be the top of your list and the bottom of your list. So I know Cahoots is based on your speed, but just make sure that you're reading and answering as best as you can. Okay, give me a few more minutes. Log in, log in. All righty. Let's get ready to start. Okay. I'm gonna go on mute because I'd be so tempted to talk. So let me just put my All right, so again, it's just a different way of, stop share and turn this thing on. So making sure you're making your list of those concepts that you need to go back in. That you are not so strong on, that's going to be the top of your list because you need to go back and spend more time with those. All right, so now let's transition to our next PowerPoint. And let's see right here. So it's opening up. I think two of them, I couldn't get my computer to add the little designs and things. I don't know why. But anywho. All right, let me share. So now we're going to look at depression and other mood disorders. Let's see. Okay. Slideshows right there from beginning. Okay, let's move this little part in. Okay, again, remember, test taking tip to just validate in what you know, your understanding. Look at those objectives and see, can you answer those objectives? That's a good way of testing your knowledge. All right, so continuum of emotional responses. The spectrum of human emotions range from elation to despair. We're excited, then we're sad. Emotional responses can be growth promoting and adaptive. They can lead to ineffective behaviors that soon could become maladaptive. So again, pay attention to the word. If it's asking you effective or is it asking you ineffective? So maladaptive is associated with being ineffective. All right, so biological evidence causes of mood disorders are complex. We talk about neurotransmitters, we're talking about the pituitary gland, biological rhythms, all of these different mechanisms that could play a part in why a person might have a mood disorder. And also those environmental stressors, those experiences that they actually have. Okay, and again, like I mentioned earlier about these theorists, these are just ways that they're just they're looking at information. So they create these theories, these different theories. So emotions in childhood, situational depression, depressive responses in children are tied to a specific event or situation. Depressed children have a distinct way of thinking. The incidence of depression in childhood is increasing. So we do have the different emotions in adolescence and throughout the life cycle. The child may experience different experiences will have different experiences than an adult. And so therefore you have different emotions just based on that, where you're at in that life cycle. As with you will have different emotions if you were an adult. Because adults must cope with a wide range of situations, events. You all have school, you have home, you have work, you have the pets, you have the children, you have the parents, just so many things that we are balancing. Okay. Okay, and it can continue even into older adulthood. So they were talking about mentioning doing our head to toe assessment when we're gathering all that information. They mentioned, as a matter of fact, it was yesterday. They said ensuring that we're listening. So as we're listening to our patients give that subjective data, We're noting they're saying, my head hurts, my, foot hurt, whatever they're saying, but also think about listen to those things that they're not saying. So then that we can refocus and ask specific questions. Okay, so mood disorders, we have mania, emotions that are elevated, expansive, so it's big, huge. And then depression is the opposite, feelings of sadness or disappointment or despair. Depression can occur on several levels. Mild depression can be short-lived, triggered by life events. Moderate depression persists over time. And then major depressive episode. This is when depression is severe and it lasts longer than 2 weeks. And these symptoms, they can range from paralysis, just agitation. But this is where it's lasting longer than 2 weeks. And with that mild depression triggered by life events, it can be triggered by something that most people conceive as being good. So it can be triggered because you're in school and you're having all these to balance school, work, play, home, and all the different things. But it can be situational. Once you're out of school, then it goes away, so to speak. So some common symptoms we need to know of major depressive disorder include sleep disturbance. You're just not sleeping as good. So when we're conducting that health history, we ask, well, how did you rest last night? Did you take naps? That's part of that. Those are some of those health history questions. So if someone is experiencing major depressive disorder, they're not getting much sleep at all. They're having those feelings of worthlessness or guilt or loss of interest or in pleasure of activities. We had a major life event, and it took my younger sister saying, "Hey, I just told you I started watching TV. It's like, like who doesn't watch TV? Well, I don't really watch TV. I don't know what I'd be doing, but I don't really watch TV. Gardening, read books, do other stuff. Playing with that old dog that I have. He's a wild one. But anyway, it took her saying, "Hey, you realize you don't watch TV? Not that I should be watching a lot of TV, but that's an activity that most people, whatever that show is that you like, or those type shows, sci-fi, mystery, whatever, but most people have something that they watch on TV." And I was like, "What? I'm not watching TV. Is that something I should be doing?" And sometimes having those conversations, how did you sleep? Do you take naps? And it'll have that person to recircle or refocus and think, shoot, I really didn't sleep much last night. Or, I'm really not doing any pleasurable activities, watching TV, exercising, or things like that. Severe depression can lead to a significant changes in appetite. People can overeat, undereat, but at the end, it will result in malnutrition. So even if they have taken too many calories, a lot of those calories are just empty calories. And so they're gaining the weight, but then they don't have the protein and all the nutrients that they need. So severe depression, you need to know, can lead to significant changes in appetite, which can be overeating or undereating. But the whole thing is it results in that person not being well nourished. Okay. Let me stop this slide. That little, when you add some of those designs to them, it messes up your stuff here. Let me go back. Remove this down or up or something. I didn't catch that. It was over the words. Okay, here we go. All right, let me share here. Pull it back up. Current slide. Okay, so we have bipolar 1 and bipolar 2. We need to know these. Bipolar 1, episodes of depression alternate with episodes of mania. So you said we have the elevation, the exuberant, overexcited, and then it alternates with depression with those episodes of mania. Okay. But then we have bipolar 2. It's a major episode of depression alternate with periods of hypomania. So it's elevation, but it's not like this regular mania, because we know this prefix means low, small. Okay, often marked by 1 to 2 weeks of severe lethargy, and they just can't get out of bed. They withdrawn. They just can't put one feet in front of the other. Okay, so with the bipolar 2, you have hypomania and bipolar. You have depression with both of them, and they alternate. So bipolar 1, you have regular mania, that elation. Okay, grandiose delusions, such as believing one has special powers or a special relationship with God. You know, they may say that they are one of the angels, and they sit. They come up with these statements of grandiose. They sit on top of the mountain, or what. It's just grandiose. They're things that they're not real, but it's excessive. So it's grandiose. It's large, and are common during manic episodes of the bipolar. So they'll tell you these different things when they're going through that manic episode. You need to know. So during manic episodes, individuals with bipolar may engage in impulsive, excessive spending, leading to financial difficulties. They may their responses or reactions are inappropriate because they're in that manic phase. They're not thinking rationally. They're not thinking, hey, if I keep withdrawing money from the account and not paying bills are not gonna get paid. So if I keep eating cheese, what's going to happen? If I keep drinking, whatever it is, but it's an impulse, so that person is having a manic episode, and it leads to other things. This example that they gave here, that impulsive spending, so it'll lead to this person being without money or any funds. Okay. Oh shoot, this is another one. But you need to know here, seasonal affective disorder. So it occurs in many people from October to April. As the seasons change, they go to fall. As we head to fall, summer gives away to fall. We start to see this seasonal affective disorder. And I asked this question the last term, not the last term, but the last few weeks. There's a place, and you all might know, and come off mute if you do know, where there's not, because the therapy is exposing the patient to light, because light, that's sitting in front of this one, the light, it's good for the body, besides the vitamin D, it's good. It lessens those symptoms of being sad. If you think about it, when we go here to fall, remember we have more nighttime hours than daytime hours and daylight hours. So there are some places on Earth where besides October to April, year round is mostly dark. They may have 1 or 2 hours of daylight. So they call it seasonal affective disorder, but for sure they say winter depression, because it's when the days are shorter. You have more nighttime hours. So again, that exposure to light therapy is how they would treat that. Okay. Substance-induced mood disorder, persistent emotional disturbance that can directly trace to the effects of the chemical, whatever the substance is. And that substance makes that person do certain things or act a certain way. All right, so treatment and therapy. Sometimes the person will require that maintenance treatment. And it's indefinite, it's ongoing. We do have medications, we have electroconvulsive therapy. I've never seen that, just only read about it, but it can happen. And then they have this transcranial direct current stimulation. It's similar to like the bone stimulators. Many of y'all may have seen those on some of your patients, but they have those bone stimulators. And so they have a transcranial direct current stimulation. But there's just different therapies and treatments out there. Exercise is considered, going to that exercise is considered a positive coping strategy, and it's a non-pharmacologic agent or intervention that can effectively help manage stress and benefit an individual's health. So the person doesn't have to just go out there and just run a marathon or, jog, extreme, but just get out there, do something besides, sitting in the chair, get out the house, just walk, even if they just walk around the house. They don't have to walk miles and miles and miles, but getting that exercise in it is a positive coping strategy. Okay. We do have antidepressants. These are, different ones, medications. So, but with the antidepressant, we want to reinforce that it's going to take 2 to 4 weeks before the effects are noted. So we want that patient to continue to take their medication because it'll take that long for that medication to get into that body, be broken down, and be utilized by the body. So the patient may say, yeah, I've been taking this medicine, for a whole week now. I haven't seen any change. We do want to re-educate and remind them, hey, some of these medications, it even takes longer than 4 weeks before they see that change. But in the event that the client does miss a dose, we want them to take that missed dose as soon as remembered, unless it's too close to the next dose. So they're taking the medication, taking it at 8 a.m., and they realize that it is 10 a.m. and they have not taken that medication. Go ahead and take that medication at 10 a.m. because the next dose is not due until 8 a.m. So almost a whole 24 hours away. But in the event that the patient is scheduled to take the medicine at 12 noon and they just remember at 11 a.m. that they forgot to take their 12 noon dose from yesterday. Well, it's almost time to take the 12 noon dose again. That would be too close. So only take the missed dose as soon as it's remembered, unless it's too close to the next dose. Okay, this helps maintain therapeutic levels because of a lot of these medications that we use. You expect your patient to get lab strong, and then therefore look for those therapeutic levels. It will show whether or not enough of this medicine has been absorbed in this patient's bloodstream and body. And so they'll have levels for you to compare. And then that's how they will determine whether or not this dose is too low, or too high, because they will get the blood drawn and they will see what the Depakote level is, so to speak, or what the lithium level is. Okay. Antidepressants, patients should be educated that they need to continue their medication. So we just talk about missing the medication. Take it unless it's too close to the next dose. But then they need to be educated to continue their medication as prescribed, even when feeling better, because we don't want them to relapse. So a lot of times, like, oh, I'm feeling better. And we kind of forget about that. Even like we have not cold medicine, but if you're taking medicine for, I don't know, you have the flu or you have pneumonia or something, you tend to, or even pain medication, you tend to forget because are you feeling better? But in order to keep that level therapeutic within range, all the same, that patient needs to continue taking that medication, even though they're feeling better. We don't want that relapse. Okay, so lithium, we need to know interaction between the level of lithium in the blood and common table salt. So the salt shaker, how you put the salt on your food. So lithium, just make sure that we're re-educating, reinforcing our patients. Hey, don't add that. If you're taking lithium, don't add that extra table salt. There's a reaction that will occur. Blood will have to be drawn. So we want to remind our patients that they're going to have to come in every so often to get that blood drawn, because we need to see if their levels are therapeutic, if they're normal. Okay. Once the client is no longer manic, the need for the lithium drugs drop dramatically. And then as they bring them off, decrease the dose, then they'll make sure that they're incorporating those coping mechanisms, those coping strategies. If they can, they'll try to decrease them, but sometimes they'll have to go back to whatever that maintenance dose was. Okay, so assess level of depression or mania. Remember, we're asking these questions when we're doing our assessment. So nursing diagnosis and therapeutic interventions, they then are chosen based on the client's most distressing problems. We know that we come the RN compiles that nursing diagnosis from the NANDA list. Okay, not sure what this slide is doing. Oh, that was the end. Let's go back to that slide. Maybe it was just a blank slide. Okay, so stop. Are there any questions about that content? Yeah, are there any questions? Okay, that was chapter 21. Of course, we're going to go ahead and validate what we know to get your list out. Those terms or concepts that you struggle with, put them at the top. So get ready to log into Kahoot. We do have a Kahoot for each of these, and it just helps reinforce what your required readings are, what they have been, and the things that we've talked about in class. Okay, wait for the pen to pull up. I'm going to share my screen here. Log in, at least with your initials. And remember, I know Kahoot, you want to get the highest score, but I need you to make sure that you're reading and understanding what the question or the scenario is about, and then answer appropriately. For a test taking tip, if an answer choice is not entirely correct, we don't choose that answer choice. So we're reading the answer choice. It's like, oh, this part is correct. But let me read on. Oh, no, we don't really do that. And don't pick that answer because it has to be all the way correct. All right, so log in. I'm going to go on mute because I'd be tempted to talk, but I want you all to think it through. All right, here we go. I can't help myself. I want to say something again. Look at the term. It says mild depression. Remember, we had those different levels of depression. It says mild. Okay. Okay. So what would we tell our patient to do for this dry mouth?
Drink more fluids, maybe, or stay hydrated.
Stay
He said
hydrated.
hard candy.
Hard candy. Hard candy is the one that mostly relieves it. But yes, make sure they're hydrated, and then that it. Okay, so let's move on here. Okay. Making sure I don't have any questions in the chat. All right.
Who was
So
first place?
who was, oh, I clicked off of it already. I'm sorry.
Oh, dang, I gotta know. I put a bet on it.
I don't know if it's a way to go back and look. I clicked
Oh,
off
it's no
off.
worries.
Yeah.
No worries.
Okay. Next time I'll let you all. I know that I'll let you all see. We have two more, so I'll let you see the next time. All right, so let's move on. Should we close up this PowerPoint? Save. So test taking tip, even though you know you have that 75 minutes to take the exam, still make sure that you're taking the time to read through and answer, making the best selection. So don't rush through because
What's the
sometimes
what's the first choice for depressants when they're trying to prescribe something?
when they're trying to prescribe something for antidepressants,
Yeah.
it's just
Is
going
it
to be
I put tricyc I can't even say it. Tricyclic
let me see,
or
let me go back to
but
it.
it was wrong. I just didn't know which one it was.
I think it was the SSRIs or something.
I think it's the SSRIs, but let me just make sure of the question. What was you said? Oh, the first What was I'm trying to find the
Yeah, they
question.
say the go-to for is the first thing they prescribe for depression.
Okay. The first choice of treatment of depression is those selective serotonin reuptake inhibitors, those SSRIs. Mm-hmm. All righty.
Thank
So
you.
here you're welcome. We're gonna transition to some more information about medications. And this one, we're gonna look at anxiety. In this PowerPoint, we do have like those questions embedded in there as well, where you can select A, B, C, or D. All right, so, and I did think the designs I picked, I think it shows, okay. All right, let me share here. Slideshow from beginning, here we go. All righty. Those are our objectives. Okay. We talked about the generalized anxiety disorder, panic, phobias, obsessive compulsive. We talked about those. Which fact characterizes generalized anxiety disorder, or GAD, GAD? And then on your paper, you can just write A, B, C, or D. But I'll give you time to read through. Question here. Clock. Okay. So you give yourself about a minute to answer the question. So just jot down A, B, C, or D. Okay. It often leads to other psychiatric disorders. Okay. Let me pause. Of all the anxiety disorders, which one is considered to be the most disabling to the patient? So, and start. Okay. Okay. Obsessive compulsive disorder. Because think about it. The question was which one is most disabling? So that obsessive compulsive disorder, that an example where we said the person might have to wash their hands 5 times before they, go to the next room or go back in the house 10 times. And so while all of them are disabling, it says most disabling. With that one, the client is more likely to not complete, get in the car and go on to work. And they're going to more than likely going to be late or completing other tasks because they're focused on whatever that compulsion is, whatever they're obsessed about. So assessment of the mental status, of course, we talked about getting all that information. How did you sleep? Do you take naps? Tell me, what did you eat for your meal this morning? What did you have for lunch? Do you have snacks? You need to know what that dietary history is. And then they have specific questions on that mini mental, so you can get their mental status. They actually give a score. And then we ask questions for clarity to determine their clarity of thought. What's an example? And you all may have seen that mini mental. Well, if it's raining outside, a person more than likely will reach for what? An umbrella or their galoshes or a raincoat or something. So just to see if their thought pattern is organized. So generalized anxiety disorder treated with psychotherapy, short-term use of anti-anxiety agents. Panic disorders may be treated with a variety of agents and behavioral therapy. Phobia is treated with use of avoidance, behavior therapy, and those benzodiazepines. Obsessive compulsive related disorders treated with behavior and psychosocial therapy. And what is this one? Prozac, sertraline. No, this is Prozac right here. Paroxetine, sertraline, fluoxetine, and fluvoxamine. So yeah, so they have a variety of medications, but it starts with those SSRIs, but then those doctors will pick what they have seen that works best in their practice. Okay, so we do have a variety of medications. There's some meds that are off-label use, and we're seeing this a lot now. Medications were designed to treat this, but now they realize that they also help and really are beneficial for other things. And so, with that being said, those beta adrenergic blocking agents are an example of that. Because, of course, those SSRIs, Paxil and Lexapro. Okay, we have all the different type therapies. You see these beta adrenergic blockers, these cardiac meds. You will see that. So when we're doing our health history and we're asking the patients about our current medicines, ask them, why are you taking this medicine? Because sometimes the patients are taking medications for that off-label use, not the reason why that medication was actually designed. And you see that a lot, like I said, with a lot of medications. So that's just another list of meds. You see those Paxil and Zoloft and Prozac pretty often. That love option you see as much. So we want to encourage the patient to deal with the problem as it occurs, even if they have to seek out support systems or say, hey, I need assistance in identifying resources, but don't pretend that the problem does not exist. So identify signs of escalating anxiety, provide safe structured environment for that release of energy. And we want to reduce that stimulation, like we talked about, decreasing that sound, that background noise. And we want to provide that patient those opportunities to tell us whatever it is that they need to tell us about how they are feeling. Okay. If the patient is in an outpatient clinic or hospital, we do want to tell them about what the rules and regulations are for where that setting that they're actually in, because we don't want them to think that it's like a one size rule for everything. So we want to make sure that we inform them of what the rules are. And involve that patient in goal setting. It's them that's receiving that care. Okay, it's just looking at those medications again. So for this one, we want to make sure that the person, if they're taking benzos, that they're coming and getting their lab work done. So we're going to be making sure that they're not, those labs, those blood cells and everything are normal. Okay. Benzodiazepines can cause rebound anxiety. You need to listen up. Upon discontinuation, this medication is DBC. Sometimes it can cause rebound anxiety and have the potential for dependence. Okay, the medicine has been discontinued. So the patient feels himself getting anxious all over again. And so the patient more than likely will want to stay on those medications or they become dependent rather than also incorporating in those coping strategies. Okay. Need to know. Benzodiazepines overdose is characterized by CNS depression. And we're assessing them that mental status is not going to be, they're not going to be alert as they normally would. Okay, that speech might even be slurred. So we want to, when we're getting that health history, you all make sure that we're asking the clients what medications they're currently on, because sometimes it can appear that a person may be intoxicated, but in fact, they're on benzos because, we have the person's sleepy, hard to arouse, they have that slur of speech that mimics someone being intoxicated. That behavior, those symptoms displayed, those assessment findings. But in fact, it could be because they're on these meds. So that's why it's so important to make sure that we're asking, the nurse should be vigilant for these signs of not that point. You go back up into this point. We want to make sure that we're collecting that patient's health history so that we can say, well, hey, this could also be because the patient's taking this medication. This could be why we are having these findings. Nurses should be vigilant for these signs of toxicity when administering these medications and report concerns immediately to the prescriber. Okay, so decreasing level of anxiety to a manageable level. Now they're realizing, okay, with this medication on board, but we still want them to incorporate those non-pharmacologic coping mechanisms as well, because we do want them on as less medication as possible. So the doctors do have to document and show that they try to decrease these meds. Sometimes they can't, but they may have to go back to the original dose or whatever that maintenance dose is, but they do have to show that they attempted. Because like I said, we do want people to not take meds if they don't have to. All right, so here we go. On your paper, just jot down. Give you a minute. All right. Which is the most common drug class used to treat anxiety disorders? Which is the most common class?
Hello?
Benzodiazepines. That's the most common class used to treat anxiety disorders. Okay. All right, here we go. So aspirins, they're short-term relief of symptoms of anxiety. And again, this person may experience that slur of speech. So again, we need to know what medications are you taking. Now you see these part pretty often being administered. So the expected outcome, that person should be if we're giving a medication if we're giving an antihypertensive, we should see that blood pressure become more towards the normal range. So the same thing, if we're giving an anti-anxiety medicine, we should see that anxiety be less. They should be able to be managing their symptoms. Okay. You see this every now and then. You used to see it quite often. Okay, it's our little timer. So notice too now, with a lot of these, a common side effect is that blurred vision. So when we're testing our patient's vision, we having to read our name tag, we having to read something in small print or whatever. Has your vision changed? Is this normal? Is this normally you have this experience is blurred? Because if not, more than likely it's going to be the side effect of these meds. So that altered mental status, that blurred vision, those are some common signs and symptoms that person might experience. But we're giving it because we want that person to experience less anxiety. Okay, here we go. What must be, give my little timer. What must be used with caution while taking anti-anxiety agents? Okay. All righty. Alcohol, gotta be careful. Okay. Because more than likely it is going to alter that mental status anyways, and it's going to further alter it. Okay, here we go. Maybe reset our timer. A series of adverse effects may be seen in a patient taking the drug Vistaril or hydroxyzine. What is the group of adverse effects classified as? Think about what that person might experience and then what category do they fall in. Okay, anticholinergics. All right, drug dependence. We want them to they may have to be on medications, but we still want the patient to incorporate those positive coping strategies because the potential is there for that patient to become dependent on that med. Antipsychotic agents may lower the seizure threshold in patients with seizure disorders and even in those with no previous history of seizures. So we want to make sure that they are aware, hey, if you already have seizures, taking this medication, and doctors, they weigh, is this glass has full, that before prescribing these meds to a patient that they know they have seizure disorders, because it's going to put them at risk for having even more of them. And also, a person that has no history of it may even experience it by taking these antipsychotics. And you're like, well, why? What's the use of taking these meds? But it doesn't. It might not occur with everyone. In the event that it does, they will, DC that medication and put that person on something else. Okay. They also may cause substantial weight gain. So patients might become non-compliant with taking their medications because they're experiencing that weight gain. So remember, we talked about exercising early on. We want to make sure because this might be that the drug for them that works best for them. So we want the client to live as independent as they can. So they might need this med. We want to encourage them. Hey, you might want to start adding exercise into your daily regimen. So a hyperglycemia and the development of diabetes has also been reported with the use of these medications. So again, it's so important that we have that client to come in, do their well checks, because we're gonna measure that weight. They may not even realize that they've gained so many pounds within a certain time frame. So when they come in, we're measuring that weight, and that can be identified. Also, they're coming in and getting those labs wrong. We can determine whether or not that glucose level, has it been stable? Looking back at the last 3 months, they may even draw that hemoglobin A1C just to see where that patient glucose has been over those past 3 months, because it may be triggering that person to develop diabetes. So bradycardia, electrolyte imbalance, presence of congenital prolongation of the QT interval. And so we might see this twisting pattern of the QRS complex. So, of course, coming in, they're going to get their weight measured. We're going to measure their vital signs. We'll get the blood work done. Then also, you will see routinely they're doing an EKG, because some of these medications can throw these patients with heart rhythms into a rhythm that can be cause the patient to actually die. So we want to make sure that we're reinforcing that teaching. Limit that table salt. Come in and get your labs drawn. If you, whatever side effects or however it's making you feel, let us know. And so that we can be proactive, because we already know that some of these medications will trigger that. Isn't that something, how taking these meds? We're trying to get them stable so that they can live productive lives, take care of themselves and their families, but then it'll trigger them to have seizures or diabetes. Because we know that going forward, we could be proactive of going ahead and setting up those appointments for your patient, those return appointments. Go ahead and get that lab work and everything done. So we're going to stop right here and take another 5-minute break. So return at 7:42. Remember, this recording still plays, so put your cameras turn your cameras off and go on mute. 7:42. And getting our Kahoot pulled up here. Okay, go ahead and log in 116050. And I'll go on mute so I let you concentrate. And I will show the winners. Remember, these are those off-label uses. These are cardiac medications, but they're used to treat phobias. All righty. Great, great, great. All right, let's move on. I'm still not seeing any questions in the chat, so if you have some, you can ask and or play. Excuse me, place it in the chat. Okay, let's look at. Okay, there we go. How's the weather where you all at? I'm waiting on my PowerPoint to pull up. How's the weather?
It's beautiful in Ohio today.
Oh, okay.
We're still getting a lot of smoke from the wildfires in Canada.
Okay.
So the sun will be orange in the morning.
Wow. How about that?
It looked orange last night.
So are they giving you all any instructions? Is like when to be outside or when not to be outside? Are they telling you all things like that?
Yeah, they have a lot of air advisories. It was really bad. I think last week, I was driving past downtown and it was the morning. I couldn't even see the skyline. It was so bad.
Wow.
Yeah, from all the smoke, like, it's and insane. I mean, all that smoke has to cross the Great Lakes. If you think about it, that's a lot of smoke.
Wow, that is a lot. I was actually there one day last week, but I wasn't really out and about in your area, but I was in the Columbus area. But I had heard about it because some students had already mentioned it the week prior. So I was like, okay. And so, but I guess I
Yeah,
really,
my one of my managers, she has really bad asthma, and so she can't come to work when it's like that. It's bad. She can't even run grill because she'll be having a what is it, a exacerbation.
exactly. And so those are things that, if you're working, especially in public health, which for the most part we are, no matter if what setting you're in, you want to have those conversations with your patients about why when they receive those warnings, water bowl, it's various warnings and precautions that they'll put out there and instructions. Talk to them about the importance of that because if you have chronic diseases, it could potentially make it worse. And so those are the conversations that you want to have. I think this is our first slide. First couple of slides always shows our objectives. Like I said, again, just make sure that you can answer those objectives and you cannot, that's where you need to start looking at that information because remember, it's going to, the bigger picture is you providing that best care for your clients because right now you're picking out your settings, you got your two lists, or may want to work here and may not want to work here. But in addition to that, you're going to have the NCLEX and the questions could be anything. And then of course, your HESI. So just make sure that you are going back through the information. Okay. So the mood disorders present with certain symptoms impair a person's ability to function for a time. Okay. Major depressive disorders, one or more episodes of depression. When we said it's all those varying, it's a trajectory. It's mild all the way to major. Okay. And so be careful when you're answering those questions. If it's saying mild depression, then that's short-lived, situational, something's going on, and once that situation resolves, it's going to clear on out. So just make sure that you're answering specifically based on what the question is asking you, because depression does have that range. Okay, so we know about those signs and symptoms: sadness, no enjoyment of usual activities, fatigue, sleep disturbance, and a lot of these mental health disorders, they kind of have some of the same symptoms. So, that alteration to me, if they're fatigued, don't take pleasure in, normal activities and things like that, that's altered mental status, you know. Think about if they're completing a task. Are they slow with completing those tasks? Or are they using the normal rhythm? Okay, I'm going to be quiet here. Let me put a minute and 29 seconds on. This one has a little bit more information for you to read through. And on your paper, you can just jot A, B, C, or D, and we'll test you here. And okay, here we go. Depression. So when a test taking tip, let me tell you about the test taking tip. It says which response by the nurse is most therapeutic. So the nurse can more than likely say all of these things, but the thing is, which one of these things are most, what's another word for therapeutic? That is not aggressive, that's not rude, that's not being disrespectful, but it's most therapeutic. Okay. So depression may be caused by a chemical, just giving us some more knowledge about what's going on with them, which medication and counseling can help. Okay. So what's the difference with B and C? If a medication and therapy don't help, electroconvulsive therapy may be an option. Are they not saying the same thing or they're saying different things? What's different about C?
I think they're saying different things because you just basically dismissed, you don't know why it's not working. You know why the medication isn't working. You just moved on to the next thing that you can do. You need to figure out what's not happening here.
Okay. Yeah. So that's what I want you to do as you're reading your answer choices. Because when they say most appropriate, another way that they will say most appropriate, this one says most therapeutic, but they'll phrase it like that. You can, let me turn my clock off. You can say those things, but is it being respectful, honest, informative to your patient? Good, thank you. All right. So symptoms usually begin abruptly and they escalate over several days. It's acute mania, euphoria, faster speech. The patients just go, they're just, everything is on fast pace. Okay. And then that's mania. So bipolar disorder, we kind of mentioned bipolar 1 and 2 on the other slides, but here it is again. They have the two different episodes that they will display. That grandeur, I own the universe. They'll say all different types of things that are grandeur. Not just like I own, the little Pinto outside, or I own the Ford truck, or that I own the whatever. It's grandeur. It's like they own, you know, the whole town that you live in. It's things like that they'll state. Okay, so then we have, of course, that lithium. Remember, we are limiting that table salt, making sure they're coming in getting their medications. Their labs wrong. We're looking at those kidney functions. Consistent fluid and sodium intake helps maintain stable lithium levels. Consistent, not over. Sudden changes can lead to toxicity or reduce effectiveness. So whatever the normal, because salt isn't a bunch of things, that normal amount. But then, sometimes we have those people that come in and pour it on. That's an excessive. That's not a consistent sodium intake. Okay. Be careful with the sodium. So in suicide, adolescent and adults most likely to have suicidal ideations. Adolescent suicide is a third leading cause of death. Then older adults, 1 and 2 attempts are successful. All right, now put my timer on. Here we go. Let's see how you do. Okay, and let's see. Okay, bipolar, because they're going from one pole to the other. Have two different, they're exhibiting two different signs signs and symptoms. One, is hyper, and the other one, they're down low. So treatment of depressive and bipolar disorders requires both non-pharmacological, those coping strategies, and also they may require medication. Okay. So remember, tell our patients, hey, it's going to take a while for this medicine and before you see the full effects. So don't give up. Of course, we want them to report if they are experiencing, adverse side effects, seizures and things like that. But just remind them that those medications is going to take a while before, and you might not want to say it's going to take a while. You want to probably use like a range. It's like, wow, what? I got to take this for a whole year before? No, for, 2 to 6 weeks. Okay. So continuation phase, 4 to 9 months, consolidates initial response into complete recovery. The goal is to prevent that relapse, I have complete recovery if possible. Prevent the reoccurrence. Okay, so then we have the different medications. Again, we're looking at these SSRIs. Those are used as well. So selecting therapy, 2 factors: patient's history of response to previously prescribed antidepressants. How did they respond? How did they do? Were they able to get back in the swing of things? Were they able to, bathe themselves, prepare meals, take care of their family, whatever those responsibilities that they had, were they able to do that or not? Okay. So potential for adverse effects associated with different antidepressants. No difference in overall efficacy, but differences in adverse effects. Okay. Just remember to tell them, hey, it's going to take a little while. You're not going to see an instant result. It takes a little while to get in your bloodstream. So again, we are getting that information from them. Clarity of thought. Remember that example that I gave? Hey, if it's raining outside, a person more than likely would grab their what? Umbrella. Umbrella is a choice. Rain boots, rain cap, things like that are reasonable to that scenario. It is raining outside. So we're noting what their mood and effect is. If they're making eye contact, no eye contact, if they're smiling, if they're frowning, or they're guarded, how is their posture? We're making note of all of that. Okay. We do want to remain calm and firm because, like I said, we're not going to change or break any rules for them. So we want to be assertive. We don't want to be rude or dishonest. But we do want to let them know what the expectation is. Keep up with their nutritional needs. Because remember, even though some of these meds may make the person overeat and they have that weight gain, but they still might not be getting the nutrients that they need. Okay. So MAOIs, they block the metabolic, can't say it, y'all, metabolic destruction of norepinephrine, dopamine, and serotonin neurotransmitters by the enzyme monoamine oxidase. So that's what they do. They block it. And as on most of these medicines, even a lot of the pain medications, they block those receptors. And that's how they work. They figured out, hey, we can block whatever this is, then this person can get back more in the rhythm. So use is most effective in atypical depression, panic disorders, and obsessive compulsive disorder, and even in some phobias. Okay, so these are our meds. Don't really see many of these. Nardil, we do kind of see sometimes. We do want to make sure that we're reinforcing to change positions slowly because of the risk for orthostatic hypotension, and ensure that we are advising our patients to make sure that they're checking that blood pressure. They have hypertension because an adverse effect of these, it increases that person's blood pressure. So it's a lot of times when you don't see many of them, but sometimes this is a drug of choice that helps that client. So you will see that. So knowing that it can cause hypertension, we will make sure that that patient knows and understand how to do those self blood pressure measurements, looking at those numbers and interpreting what they actually say so they can make those phone calls in the event that blood pressure, is really, really extremely high. Okay. Blood pressure, pulse rate. Sure the patient has not recently ingested meals with a high tyramine content. So, what are some foods that have high tyramine content, you all?
Aged cheese.
Exactly. This would have come from med-surg. So we want to encourage them to don't eat those. Okay. So when we're doing that history, they say that, hey, I'm taking, certain medications, we want to ask them, what, have you eaten any of these food items? Monitor that blood glucose in those diabetic patients. Check that blood pressure. All right. So here we're down to another question. Set my timer. Give you a little time and go. And here we go. Rise slowly from a reclining position. We'll just talk about that orthostatic hypertension that they potentially could cause. All right, those SSRIs, Celexa, Prozac, Paxil, Zoloft. How do they work? Their action is they inhibit, they stop, block the reuptake and the destruction of that serotonin from that synaptic cleft, prolonging the action of that neurotransmitter. Okay, these are widely used antidepressants. Suicidal ideation is an adverse effect of it, though. So we want to make sure that we're asking our clients, do you have any thoughts of, harming yourself? Okay, that's CNS alteration. If they are on warfarin, which people are kind of trending away from that, but if they are like our older population, you see a lot of them on warfarin, be careful. If it enhances the anticoagulant effect, what do we need to tell them? If they're taking warfarin, and we know that these medications, these SSRIs, enhance the anticoagulant effect, what are some nursing interventions that we want to, patient teaching that we want to do for our client? And or UAP, if we have a UAP that's providing care for this client, what do we want to tell them? We're responding to this. Warfarin enhances anticoagulant effect. What does that mean? So what is it to coagulate?
Like
So
helping clot the blood.
Okay, so if it's an anticoagulant, what's going to happen to that blood? It's not going to be
It's
clotting
not going
like it.
to clot.
Exactly. So go ahead and say it. Go ahead.
So it's not going to clot. It'll be
Exactly.
thin, like runny.
Exactly. So if the person is taking this, we already know that's what warfarin does, and they end up on one of these, what's going to happen? What are they put at high risk for doing what? If they get a cut from a razor or any type of cut on them or opening in the skin, they're at risk for what?
Bleeding out.
Bleeding out. An example is patient had a Foley catheter. Patient was coming in, had an episode. I think the patient ended up maybe having a heart attack or something. But the patient had been taking warfarin. They had put a Foley catheter in that patient. Patient had gotten better, was getting ready to be discharged. They moved. That patient ended up getting up from the bed, the chair, something. Long or short is snatched or pulled on that Foley catheter. That client required, because they were already on warfarin, they were on one of these medications, and it enhanced the anticoagulant effect. That client required fresh frozen plasma, a pack blood. I think he ended up getting 2 packs of blood cells because it enhances that. It puts that person at risk for bleeding even more. And then if something happens, an opening is there, it is not going to readily clot. So yeah, so make sure that we're teaching them that, hey, you're shaving, you might want to get an electric razor. You want to be careful when you're out there in that yard because you've learned, you know what your patient likes to do. They like to garden or whatever. You're out there, the rose bush or snag your hand, get that opening in that skin. That person is at risk for bleeding out. So long-term side effects of lithium can include thyroid problems, such as hypothyroidism. So it's another reason for that person to come in and get those lab works done. The glucose level, we measure their blood pressure. We're gonna get those, look at those blood cells to determine whether they're having those blood dyscrasias, and we need to get that thyroid level as well to see if this medication is affecting that thyroid from functioning like it's supposed to. Sexual dysfunction, including decreased libido. Patient may come and say, hey, because you've established that therapeutic relationship, they'll tell you everything. And you want them to, because then you know whether or not how these medications are affecting them. Okay. All right, another question. Timer will give you a minute. Okay, and here we go. Increased risk for bleeding because they're taking them at the same time. Okay, they're taking this because they have this disorder. Then, so the treatment of choice is to give them this medication that thins the blood. But because we know that these type medications also enhances that anticoagulant effect, there is for bleeding. That's real. So we have some more medications here that we have listed. Cymbalta, you still see Cymbalta and Fixer. I don't see these others as much. That dizziness, that drowsiness, that alteration mental status. So that's pretty much common side effects. You do want to ask them, making sure that they're not having any suicidal ideations. And that's unfortunate that these medications, they help, but then they may trigger that. I forget the medication. They were announcing on the TV the other day. It's like, well, you start to have vivid dreams. I'm like, oh, wow, what is that medicine? I forget what it was for, but it helped whatever it was, but it could cause all these other issues. Okay. That orthostatic hypertension, that blurred vision, checking that blood pressure, you all getting those lab work done. So patients' education, drug may cause orthostatic hypertension. Like I said, a lot of them, these medications, they have almost the same side effects. That dry mouth, we're encouraging to stay hydrated, eat that hard candy. They may be have a sedative effect. So you want to be careful with operating machinery and driving until you know how this medication is going to affect you. Okay, here we go. And just jot down which letter you think is correct. And this one says select all that apply. Okay. Okay. So the patient that has the shingles outbreak, the limb pain, and then the cancer pain. All of those are in some type of discomfort. Now, this appendicitis is pain too, but these are a different type. These are like chronic pain. Because shingles, they have that because it's following the shingles outbreak. This is after, so this is chronic. This is acute. You see how, okay, if you knew this was the answer, you wanted to look and see was there anything else that matched. A patient with pain following after. So this is chronic. This patient's not having pain at all, so we know that about this person. And then if we were trying to determine between acute pain, this person with this appendicitis, wait a minute, this person is acute. I've selected these other people with pain, but their pain is more chronic. This phantom pain is after that limb has been cut off. Patient with cancer pain, that's after they've been diagnosed. Okay. So yeah, we see the Remeron and the trazodone, but you can see all of them. But once you work in certain settings, you'll notice, or if you're in certain areas, certain providers will start off. They have a starting point, which means they'll try first and then next and next. Okay, so these anti-manic agents, of course, they should be reducing the mania, preventing those reoccurrent cycles. So, of course, we're looking at those electrolytes, those kidney functions, and those thyroid functions. Okay. Food drug interactions that increase the risk of toxicity, diuretics, sodium levels, that endomethacin, and I can't remember what it's given for right now. So we draw labs. We want that patient to come in and get those labs drawn because we want to see if their levels are therapeutic. If the client's level was 2.0, is that therapeutic, you all, according to this? If the clients had blood drawn, if their level was 2.0, is it therapeutic? Is it therapeutic and normal mean the same thing? So
No, because it would be over
got it.
more.
Got it. Okay, here's another question. Which is most likely associated, with a sign or symptom of lithium toxicity? And lethargy, that changing that mental status. All righty. We're almost there, you all. Okay, let's see. That was chapter 16. What time? And you know what time it is. It's Kahoot time. Chapter 16. Trying to pull it up. Okay. Log in, and here we go. All righty, let's see how to be fair. All right. Y'all did pretty good. Where would the little bar go to? Okay. All righty. So I know we didn't go over the orientation PowerPoint, but I do like to bring to y'all's attention those sites. And I don't know if y'all would be on any to because y'all are just taking the exam and you have your quizzes and everything is in SurePad. But just overall, staff those restricted sites, you all, because that thing is real. I don't know who sits out there and watch it, but don't just go in and looking, shopping around and just seeing what people are looking at. Just stay away from those sites, you all. Stay away from them. And then the attendance thing too. So remember you may or may not get those notifications about your attendance. So make sure that you're keeping up with that. So you know where you're at. Have any documentation. If you're getting too late, if you had a flat tire, take a picture of the tire, the receipt. I'm just calling out things that that might happen because we know life happens. So just make sure you have supportive documentation. All righty. And here we go. So we're getting ready to look at drugs that are used for psychosis. All right, let me share here. Look at my timer here. So it's almost time. So it's 3 minutes before we take another 5-minute break. We can take that 5-minute break at 8:30 and then come back at the appropriate time. But we still have our 10 minutes stored away. So either way, at a minimum, we would finish at 8:56. Now, if you wanted to, if you all, we have to have a consensus here, majority. If you all wanted to if you need a break, you just need a break, and that's fine because we have it there. You could move that 5 minutes in addition to the other 10 minutes that we already have saved up. And then that would make us get out at 8:51. But otherwise, we're gonna take a break here in about 2 more minutes. And then we're almost there. So just stay with me. Remember, this is a lot of information, but 3 weeks and we're done with this. So just make sure that those slideshows are here. And again, those objectives. Oh, go back. Go back. Too far. Yes. So psychosis, no exact definition term used as a clinical descriptor. This other way. Characteristics being out of touch with reality. Perceptual deficits like hallucinations or delusions, just not, in touch with what's really going on. It's raining outside. They think the sun is shining. Psychotic symptoms can be associated with illnesses like dementia and common in mood disorders. And also if a person is on substances, alcoholic substances or different substances like that. Symptoms would be the delusions and the hallucination, the disorganization of thoughts and behaviors. Their thoughts and behaviors and the things that they're saying are just not appropriate. Okay, so here we go. A patient states that voices are telling her she is evil and that she should leave the hospital. From which condition is the patient suffering? So that question, again, another test taking tip, you can just paraphrase, this question is asking which one of those diagnoses does this patient probably have? That's just another way of rewording that. So don't get tripped up on those words. Okay. And on your paper, you're jotting A, B, C, or D. She's hearing voices just telling her that she's evil and that she should leave the hospital. Okay. Hallucinations. All right. So the treatment for psychosis focus on decreasing those symptoms that are interfering with this person functioning normally. Being able to bathe themselves, change clothes, take out the trash and those things like that. Target symptoms are critical monitoring parameters used to assess clinical status and response to drug therapy. We want to consider, as always, non-pharmacologic and pharmacologic, so meds and no meds. What other strategies or tools are out there that this patient can actually use? We want to determine what the patient's baseline level of functioning is. What could this patient do? What was their baseline anyways? So we'll have that for comparison. Okay. All right. So we are going to stop here for a 5-minute break. And then when we come back, we will have about 20 minutes to go. So I will see you back at, what time is it? 8:32. So 8:37. See you soon.
Come here, Joel. Did you? Let me out.
Christian, Okay, let's see here. Almost done. I would encourage you to go back and make sure that you're reviewing your classroom recordings, looking at that list of concepts that you've written down that's, from the ones you need to spend more time with so that you can gain a better understanding of it. But for sure, go back to our classroom recordings because we're covering, everything. And I know it's a lot, but just chunk it up and go back and look through it. Okay. So we're talking about adverse effects, these antipsychotics. Person may even experience this pseudo Parkinson, like it will appear that they have Parkinson's. They will have that shuffling gait. They will lose weakness. They can't. Their motor function can't hold a pencil or a pen. Okay? That weight gain, hyperglycemia. We talked about that, but we're also adding in this lipid, the cholesterol panel. So they need to have those levels done so we can monitor and see what those glucoses are done, those kidney functions, see what their cholesterol levels are done. We've talked about already these medications have the potential for making people gain weight. So we need to be discussing diet and exercise strategies. Okay, and the possibility of medications adjustments. So we incorporate positive coping strategies. Hopefully we can take this patient off these medications and then it lessens the chances of that patient gaining weight. But nevertheless, we do want to talk about those dietary interventions. Okay. This is just telling us how they work. They block those receptors. Again, we're gathering all that information from the client. We need to know what they're eating because remember, if they have high pteramine food, if they're adding extra salt to their diet, we need to know. If they're thinking, is their thought process reasonable or is it irrational? So we need to make sure that we're getting all of that information. Okay. Keeping that environment safe and structured, that helps them to, stay focused. And also it lessens the chances of them becoming suspicious that we're doing something that, to harm them. We want to always provide that orientation. We have to reorientate to reality. Okay, here we go. Patient has been admitted for further treatment of a psychotic disorder. After 5 days, the patient reports fatigue, dizziness, dry mouth, and constipation. The nurse explains to the patient that these symptoms are due to which factor related to the prescribed antipsychotic medication. Are these examples of toxicity, common adverse effects, serious adverse effects, or allergic response? Okay. Common adverse effects. Got it. Here we go. A patient with a history of schizophrenia has been on antipsychotic medications for a prolonged time. They did not just start this. Patient is exhibiting new symptoms of tremors, hypotension, and tardive dyskinesia. So it says new. So this is new for this person. Lab results show an increase in liver enzymes. What does the nurse suspect? Okay. These are serious effects of medications and the healthcare provider must be notified. Again, these sets, they block that dopamine, the action of the dopamine. For the most part, all of these block something. So again, we're looking at everything, assessing all of those body systems. Make sure that they're functioning like they're supposed to. And remember, how do we know that the urinary system the kidneys are functioning like they're supposed to? Gotta get those labs. Blurred vision, the fatigue, those are common side effects of these medicines. We need to make sure we get that blood count because they have the tendency to alter those blood cells. Okay. A patient has been taking an antipsychotic agent for 2 days. When suddenly his eyes roll back and a jaw drops, his jaw develops spasms. The nurse notifies the prescriber that the patient is experiencing eyes roll back and the jaw drops, developing spasms. Huh? Dystonia. Got it. Which symptoms are most likely, this is select all that apply, associated with the neuroleptic malignant syndrome? So select all that apply. More than likely, there's more than one correct answer because it's telling you. Select all that apply. Okay. Lead pipe rigidity, that comatose state, and hypertension. All right. Are there any questions about that? We still have about 10 minutes. 10 minutes? Yes, 10 minutes. So that was chapter 17. So we do have one more, and what'll happen is we'll start on it and we'll run out because your time is going to end at 8:56. But what'll happen is I'll just stay on and just review it. So you'll have it all reviewed in your recording. So I want you to go back through these recordings. Make sure you're listening, looking at what's there, and chapter 30. It's not as long. It doesn't have that many slides. And in between time, if you have questions about a concept, you can send an email. We don't have to get on Zoom, but if we need to, we can. We can talk over the phone, or you can send an email exchange. Now, Dr. Bugs Cutler, she will do an exam review. So know that that will be coming. She does it closer. She does it next week, so I have to look at the date and see. But then before the exam in week 3, we actually review before we start the exam. But no, you do need to come with that foundational knowledge and get understanding of everything. So stress and coping is a continual process that starts with an event that is experienced by the individual, perceived through intact information, their processing channels. Like, how are they perceive? How is this person perceiving this? Remember that the example I gave you about me taking the trash out. One scenario, I was happy-go-lucky, getting that trash out of there so that they could pick it up. Next scenario, I was afraid. So coping. So even though there's a threat within the current capacity of coping skills, resources, and abilities, ending ideally in a positive outcome. When we're coping, even if we have to seek out the assistance of support system, it will lead to positive outcomes. So coping is defined, we need to know, as an action directed toward change through conscious or unconscious thoughts and behaviors to avoid harm and restore balance. So is a continuum of stress neutral, challenge, or manageable, and then sometimes it becomes you can't manage it. Okay, so of course we look at each body system. How is that stress? What is the stress response? Sometimes people will break out in hives. What is the stress response of the skin? What is the stress response on the cardiac? Sometimes that heart rate will increase. Okay, we do have different sources and types of stress that are cognitive appraisal. We need to think about the age, the person's developmental, like are they an adolescent, older adult? We need to think about that. Chronic stress produces negative outcomes across multiple body systems. Some people even will experience achy joints, a decreased libido. Think about all the different, how a person would respond. Infants, they may not be aware of what's going on, but still they can sense. So they may cry, can't be consoled. That older adult, how everyone is at risk for this stress, but how will we be coping? What are some things that put people at risk for stress? Financial strain, strained family relationships, just not getting along in the family. Something has happened. The leader of the family, so to speak, has passed away. So what are the next steps? Who takes those reins of being that leader and guiding that family? So of course we want to get that history. We talked about that. Got to get that history. We're promoting effective coping in health and well-being. We want them to exercise. That has been you all exercise. Don't forget that. So stress screening tools available. No national recommendation on general stress screening. The recommendations for screening in situations related to mental health that are linked to ineffective or maladaptive coping. And so a person may end up being depressed, or they may end up abusing substances. Okay, so collaborative interventions geared toward reducing actual, and sometimes it's a perceived threat. Okay, we do want to provide that reinforcement, those options, so that they can gain an understanding, so they can have some positive coping strategies. You know, things happen. Nobody's uh, uh, can be eliminated from things happening, but how are we going to respond? Even if that response is seeking out, telling someone I need some help to find out some more help. So how is that response going to be? So problem focus coping, emotion focused coping, that deep breathing technique. Remember I told you all about the patients that come in, we have them sit down, take those couple of deep breaths in and out before we measure that blood pressure. That's emotion focus. A lot of times, they're in a rush, or they're afraid about what the doctor's going to tell them. So we want to, refocus that emotion. Okay, coping strategies, support system, exercise, music therapy, relaxation strategies. Ineffective, avoidance, that's ineffective. Being in denial, overeating, ineffective. Okay. So these are some medications which we talked about those. And remember, sometimes it's, for that moment in time. It doesn't mean that because this person's going to need medicines today, that means that they're going to be on these medicines forever. Okay. So some examples: anxiety disorder, tension headache. These are things a person may experience if they're experiencing, that certain level of stress. What powerful tool will increase self-efficacy and control for a person who is stressed? Self-perception, denial, education, or maladaptive coping? Education is the key. Education regarding the situation, understanding what's going on, understanding that this person do have options. Education regarding the situation and alternative coping measures is a powerful tool to increase self-efficacy and control, because we want that person to be independent. So just informing them, okay, this is a situation. We're in it. What can we do about the situation? Identify some resources and tools, and maybe some key people to assist. Okay, what factors may cause an individual to be at risk for negative outcomes for stress? What are some factors? Okay. Individuals who are very young may not develop adequate coping strategies. So the brain may still be developed if they're very young, more than likely. Adolescents are still developing and are high risk for choosing ineffective coping strategies in times of stress. Older adults may have loss of mobility and may have a reduced social structure support in times of stress. Because, like, for example, people that may have several siblings, and those siblings may have been the support system. If they passed away, then who is there? So age is going to be there. So the age. Okay, which of the following is a body system